Okay, you guys, thanks for coming. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Department in the training space. My name's Sean Barinholtz. I'm anesthesia and critical care at Hopkins. I'm a member here at Pikesville, and I have an honor of serving in the medical director's office. On behalf of the medical director's office, Dr. Vitberg, Dr. Sagal, who will be here shortly, I believe, Captain Willits, also, thanks for joining us. Thanks for being here. We definitely want to help acknowledge you for the work that you do, as well as for your dedication to lifelong learning. We're very thankful to be live streaming this yet again. We're continuing to create more outreach, making this stuff available for more providers across the state and across the country. Big shout out to Ashley Brooks, who is the mastermind of this ability to live stream and to be able to figure out how to do that affordably and reliably. So tonight we have Dr. Dave Vitberg and his team. Dave's going to do an EMS case review. Dr. Vitberg is board certified in critical care, emergency medicine, and internal medicine. He's currently the deputy medical director of the Baltimore County Fire Department, a member of the R. Adam Cowley Shock Trauma Go Team, and division chief for medical and surgical critical care medicine at GBMC. I also know that Dave is a very gifted and dedicated educator. So for that, we thank you so much.
All right, thank you very much. So just to continue the nicey-niceys, I just want to thank Sean Barinholtz for creating this lecture series. Having been involved in EMS since I was the tender age of 17 and having a very, very big even birthday in my 40th decade next week, I can tell you that this is one of the most high quality educational experiences that I've either sat in and consumed or had the fortunate part to be a part of. So thank you, Sean, for setting this up. I want to just introduce who is presenting tonight, and then I want to tell you why we're doing this. And then I just want to kind of give you the layout of how tonight's, I hesitate to call it a lecture because what we're aiming for is not to kill you by PowerPoint, but to actually engage all of you in a little bit of a discussion. A couple people that we have tonight. So the picture on the announcement should have been that of Missy Schuler, who is EMS 2D. She came to me a couple months ago with a request for a case review, and we actually had an amazing case review with NICU staff at GBMC, the director, Maria Payne, and one of the nurse practitioners, Cynthia Arnold. And it was Lindsay Goff, who is a former Station 5 paramedic, Missy, myself, and the two staff from the GBMC NICU, and we sat there for about an hour and change talking about this incredible case that we're going to share with you tonight. And I said, man, there are like 100 to 300 people in Baltimore County Fire Department that engage in EMS that need to hear this. And what's unfortunate is we do a ton of case reviews, the medical directors, and usually it's a small group of people sitting in the room. And we don't yet have a very, very robust mechanism to share that content and share that learning with the department. I think most of you would agree we could probably do a little bit better with communication in the department from the top down and the bottom up. And so this is my effort to improve that communication and take some of that learning from that case review and share it with everybody sitting here tonight, those of you that are on the live stream, and hopefully you guys can share this learning with the other folks that you ride with. So thank you, Missy, for joining us. Lindsay rearranged her schedule to be here tonight. She was part of the call that you're going to hear about tonight, and she surprised me by showing up tonight, so I wanted to say thank you to her. Sitting over here, we have two folks from GBMC, Christian NICU, which is a level 3 NICU, and I have Rachel Farbman, who's the nurse manager of labor and delivery. So it's a two-for tonight, two managers for the price of one, and they are going to share their clinical expertise with us as we review the case. So the way this is going to work is Missy's going to present some basic principles of neonatal care, which I would argue if we were going to make a list of very, very high acuity call, low frequency calls, neonatal care, neonatal resuscitation would fall in that bucket. And it's my philosophy in my ICU that I drill down with my docs and my nurses those very low frequency, high acuity situations that we have to be prepared to manage. And I'll speak for myself, I am not comfortable managing neonatal calls, and any opportunity like this I'm going to grasp onto to try to improve my care of neonates. After Missy presents the 101s, Missy and Lindsay are going to present the case that they shared with me a couple months ago and we reviewed. And then we're going to have the GBMC NICU and L&D staff join us for kind of a roundtable discussion of that case and principles of neonatal resuscitation and care. And then we're going to finish up with a little friendly competition. We'll kind of split the room, maybe career versus volunteer, or bald people versus people with hair. And I have a gift card, $50 gift card to what's the barbecue place that we all eat and drink? Mission Barbecue. And whichever team wins that, I'll give somebody the card. You guys can go all get a bite to eat. How does that sound? Does that sound all right? Okay. So without further ado, I'm going to turn it over to Missy.
All right, good evening, everybody. My name is Missy Schuler. I'm the lieutenant at EMS 2. I'm apparently being told to hook this up. Sorry. That's even better. All right, so I'm EMS 2 on D shift. Lindsay and I had a call that not really any paramedics that I know of or lieutenants that I know of have had to go through. Unfortunately, I've been gifted the gift of not one normal delivery of any of the childbirths that I've had, so this is kind of a frequent occurrence for myself. So we have a couple objectives that we're going to meet. I'm not one to stand still, so if you need to follow me, then I don't know what to tell you. Brief introduction, we just pretty much did that. We're going to discuss some prenatal risks that would complicate even a full-term childbirth or premature childbirth. Key points for the management of a preterm delivery in the field. We're going to discuss our case study with the 20 to 22 weeker that we had, and strategies to ensure the family is also taken care of after the situation that we dealt with. So my motivation behind this happens to be my son. That's him. He was born at 31 weeks and 2 days. We spent 2.5 months in the NICU. So I'm pretty driven to learn about neonatal care because I wanted to say, just like he said, it doesn't happen often, but if I am going to be faced with it, I want to be able to resuscitate and take care of a child. So adults versus newborns. Often adult resuscitation is a result of what? Trauma or cardiac issues. Pediatric or babies, neonates typically require resuscitation due to respiratory failure. That's one of the #1 causes of pediatric or neonatal resuscitation. Some of the prenatal risk factors: gestational age of less than 36 or greater than 41. No prenatal care, which is what we had in one of our case. Preeclampsia or eclampsia. HELP syndrome. Multiples, magnesium therapy, placental abruption, meconium, maternal substance abuse, acute stress. Any questions on that? Yes?
What's HELP syndrome?
HELP syndrome is, I mean, you guys would probably be a little bit better at that, but it is essentially a hypertensive crisis. In moms that don't have like the protein spilling over into the urine, it causes a lot of the same type symptoms that eclampsia and preeclampsia will do.
It stands for hemolysis, elevated liver enzymes.
Thank you. I knew there's a lot of. Yeah.
Just for those, can you quickly the difference between preeclampsia and eclampsia?
Again.
Eclampsia is when you have a seizure. Preeclampsia is elevated blood pressure, you have elevated labs, and then when you become eclamptic is when you actually seize.
In a lot of different cases, I mean, obviously there's different presentations for both of them. I was eclamptic, but I had no actual seizures, which is why he was born super early. So now we have, why are preterm babies at higher risk for complications? So name some of the things that we would consider for preterm deliveries as a higher risk. Like what can cause a higher risk for some of these babies once they come out? Okay, immature lungs. What else? This is a group discussion.
Sepsis if the mother was infected.
Okay, sepsis if the mom has some issues. Okay, airway compromise. Yes.
Cardiac shots.
Okay. What else? What about their thin skin? Lack of sub-Q tissue. Thermoregulation. They tend to metabolize things differently than full-term babies do. Those kind of things are listed. So we have limited metabolic responses. We have lungs that are immature, lack surfactant, which is another thing. Increased risks for infections, small blood volume, chest muscles. These are just a few of them. There's a whole slew of them if you take the NRP courses or STABLE or any of the other courses that have heard of that go into this. This is just a few of them just so we don't do death by PowerPoint. We will have a good discussion later on. So in the field, how do we determine gestational age? The mother, okay, ask. What if the mother doesn't know? What if the mother doesn't know?
Height up to the umbilicus, height of the bundle.
Okay. Any other? So again, there's a few things that we can think of. In our department and in EMS, there's really no set clear protocols as to saying how we determine gestational age of a baby outside of asking the mom. Last menstrual period. When was the last time you went to the doctor? Have you had your anatomy scan? Which is a question that we had to ask our mom. None of those questions were able to be determined. She said, maybe about 5 months. So it wasn't really a reliable gestational age. So currently we have an APGAR scoring. So once the baby's born, we have to evaluate via APGAR, right? Whether or not they're APGAR scores. We all know what that looks like. It's in our protocols. We discuss this all the time when we have a new healthy born baby. But again, any of our premature babies or babies that are having complications are pretty much going to have a very low APGAR score. So again, if we have a premature infant that we haven't been able to determine gestational age or viability, this is what we have right now. We have no set guidelines, no set protocols, which is why we're doing this class to help encourage people to learn and better themselves in the field of having to make a decision. So things to consider in determining gestational age or viability. The years, the genitalias, and posture, and their weight. In the medics in Baltimore County, do we carry a little gram scale? No. I mean, unless you have a food scale in your bag, then I really don't think we're determining weights. So we go on to skin texture. Prior to 24 weeks gestational age, skin textures are very gelatinous, thin, visibility of the venous structure is present. It looks red, you can pretty much see through it. Some of the bone structure, subacute tissues, visible blood vessels. Plantar creases. Everybody knows the little creases on your baby's feet when they come out all nice and cuddly and cute, and their feet are, you look at them all, they're all wrinkly. If they lack them, it's more likely that they are premature infants. Like that. Versus that. So that of a 22-weeker on the left, that of a 39-weeker on the right. Eyes and ears. Obviously, we are going to say eyes are evaluated in the field as either open or fused. Gestational age below 24 weeks tend to have fused eyelids. So if we have a 24-weeker and their eyelids are fused, all of this is subject to change because each baby changes. Every baby grows differently inside a mom, but typically that's been known. Ears in extreme prematurity are very pliable. They lack the cartilage. So typically if you have a baby that comes out and you're wiggling their ears and you're looking at their ears trying to determine viability and gestational age, you can pretty much say that a premature neonate is soft and pliable. Posture. When we discuss posture in the field, what do we think of? Brain injury. Okay. Or how about somebody sitting? Like if we're sitting up and we have an adult call and you're tripoding or you're working to breathe, if you have lack of any sort of function, like you said, decorticate or corticate posturing, as a baby, it's kind of the same thing. Whether or not they have muscle tone, whether or not they're trying to move all around, or whether or not they're limp and flimsy. So if we have a limp and flimsy, again, how the baby holds their arm, here's 3 different gestational ages. It goes from 24 to full term. So you can see the difference in posture in those 3 infants. All of them completely different. It may not look like a little bit between the first 2, but just how their arms are being held and their legs shows a big significant difference in my eyes. So rapid evaluation of baby, right? Baby comes out, either you delivered it or delivered pre your arrival. What are we doing? What's the rapid evaluation? What's our first step? Okay, breathing. What do we do next? Okay, APGAR scores. What else?
Where is the baby located?
That's a great question, yes. But if you have baby in your hands, warming, dry, what else are we doing? If the baby's not crying, baby's not really stimulating, what else are we doing if they had meconium staining? Suctioning. All of these things we're going to be doing rapidly, right? But even better, we're doing a rapid evaluation. Is the baby term? What gestational age are they? Because it's going to have to get more in depth than that sometimes, because you may come up on a baby who looks to be 30 weeks. Mom says it's 30 weeks, but there's different things that they're going to have. So you have term, tone, breathing, or crying. Really, really quick things that you can say. All of those things are great, but if we look at it just in this little thing, if they're term, what's their tone, and are they breathing or crying? You've pretty much done the pediatric triangle or the newborn triangle very quickly. So what do you do now? If you have a preterm baby, what do you do? Keep them warm. Okay, we'll get into ideas on how to keep the babies warm. Check the heart rate. How are we going to check the heart rate? Okay, umbilical pulse. I saw you looking up brachial pulse. Stethoscope. So those are the main ways of checking pulses in the field. So my theory, and again, we do this all the time, BLS, 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 and then ALS. On our pediatric triangle, ALS comes last. Why? If you don't have an airway, we don't have a baby, right? If we don't have a pulse on a baby, or the baby's super bradycardic, we have a really sick baby. Again, all of that stuff is managed BLS. Bag valve ventilations, BLS skill. Number 1 reason why neonates need resuscitation, typically, obviously there's outliers that go out there, is respiratory. If we don't have an airway, we don't have a good baby. Once the decision's made to resuscitate, that is what we have right now in our protocols, right? So, in Lindsay's and my case, we'll get into it a little bit further, this really wasn't an option for us. It just wasn't. We made a really tough decision, and ultimately it was the right decision, but again, this was not an option for us. Keep them warm, right? You said it earlier. How can we keep these little teeny tiny neonate preemies warm? Where you carry, does everybody carry saran wrap in their medic? That is nice if they're in a kitchen at their home. Okay, body heat, skin to skin. I'm a huge advocate for that, as long as the baby's able to be monitored and treated without their mom being there, or with their mom being there. What about your OB kit? What's in your OB kit that we can keep them warm with? Hats. There's a couple little things, depending on the size of the baby, that we have that we open up, and on the inside of it is sterile. Shove the baby in the little plastic wrap. We can resuscitate them up that way. Keep them warm as possible. We can put plastic bags, like sandwich bags on them, gallon-sized sandwich bags. In the middle of the summer, what do you have on in the back of your medic? Air conditioning. Why? Because we're hot. What about the baby? What about the mom? Both of those people are going to be cold at this point in time, and we really, in order to resuscitate a baby, we have to have a warm baby, because if we start taking away their temperature and their warmth, we reduce their metabolic activity. So thin skin, no fat leads to a tremendous chance of heat loss. Again, it's not about us. Dry them off and use plastic bags, whatever you can use. Blankets, and if stable enough, skin to skin. I'm a big fan of that. That's one of the biggest things that in the NICU and I think in labor and delivery, we try to encourage that all the time. If you can do skin to skin, if mom's willing to do skin to skin and the baby's stable enough to do skin to skin, please encourage it. And whatever happens back there happens. Positive pressure ventilation. So let's say the baby's having some respiratory issues. We need to ventilate the baby. Do we have neonatal preemie resuscitation bags that are medics? No.
Career volunteer, what is the
Very accurate statement. We typically don't have premature neonate bags in our medics. So proper size bag is very, very important if you're going to be providing PPV. Again, one reason why they have it is respiratory compromise. This, I think, and I mean, I don't know if everybody can agree, but this to me is one of the #1 single skill that's important for resuscitating babies. Good positive pressure ventilation if that's a requirement. Oftentimes in premature babies, we have some people with some gigantic hands come in, grab the bag valve mask and start squeezing away as hard as they can because it's a nerve-wracking thing and it's probably the only time they're ever going to have to do this in their career. That if you take your bag valve mask, the actual mask, in your dominant hand and make the seal on the face, you have a better chance of getting a good proper seal. In your non-dominant hand, you use the bag with your ring and thumb finger because it decreases the chance of overinflation into the preemie's lungs. Something simple, something super, I would have never thought of it in a million years because ideally I hold it with here and I squeeze with my right hand. That's how I do it. I don't know how everybody else does it. But something as simple as that. That's a little tip, trade thing that we can do. And proper positioning is one of the #1 reasons why we don't get good mask ventilation. Yes?
When you say skin to skin, do you mean during transport?
If
And also, should mom and baby be transported together or should we be calling for another transport?
So I think that can go both ways. I think if the baby is stable enough, we transport full-term babies together with mom. I think if the baby is stable enough and mom is healthy enough and no other complications are in line, I think it's a scene-to-scene dependent thing. Had the baby that you and I had been viable, probably not the most appropriate time to have that. I did deliver a 33-weeker and we delivered mom and baby and mom nursed the whole entire way to the hospital, skin to skin. So I think it's situational dependent.
comment on the second part of that question? What was that?
The second part was should mom and baby be transported together or should we be calling for another transport?
About skin to skin. In between the chest, in between the breasts, with a blanket over top of them, keeping them warm as possible. Typically the baby will adapt to the mom's temperature. Mom's typically a little bit hyperthermic at the time of delivery anyways because their bodies are working a little bit harder. So the babies tend to adapt to the mom's temperature. Obviously if we have a cold environment in the back of the medic unit, we really need to adapt it to a warmer environment. So I think it's, again, situationally dependent based upon stability of both mom and baby. Did that answer? So this is a couple questions that I have. So how many of you guys have either delivered in the field or arrived shortly thereafter? Okay. How many were full-term deliveries? So pretty much everybody. Okay. When you were going en route to those calls, were you guys thinking in the back of your head, holy cow, what happens if this baby's not breathing and they don't have a pulse? Okay, some say yes, some say no. I can tell you my first one, I wasn't expecting it. So I've learned to come to expect that because it seems to be my trend. How many of them actually required any sort of resuscitation, whether it be excessive stimulation, excessive suctioning, bag valve masks? So maybe 1 or 2. How many of you have actually delivered a premature infant? What was the GA, or gestational age? Okay. So we'll ask some questions from you in a minute. So with the scenario that Lindsay and I are going to present, we had a really tough call to make. So how many of you actually had to make the decision to work or not work our babies? It's a really crappy decision to make, for lack of better words. Again, a lot goes into that decision, and of course, I don't know how it went, but I know how ours went. So with that, we are going to discuss this case. Yes?
I'm just curious, Kristen, Rachel, with the information you just heard, is there any additional pearls you can give on basics management? A+ honors? Yeah. Okay.
Please, if you think of anything, please, by all means, interject. And that comes from all of you guys too. So with this case study that we had, I'm just going to kind of briefly, in my slide presentation, I have it reversed a little bit as to how it was dispatched to us. So I'm going to read off of an email that I sent out to request the case review to Dr. Vitberg. So originally the call came out with the medic from Medic 375, or 365, I'm sorry, 365. The initial dispatch was a maternity with bleeding, possibly second trimester. That was how it was initially dispatched to us. I think, yeah. I said not emergency, sick with vaginal bleeding. It was then quickly upgraded to, in between that, it was upgraded to childbirth imminent. So childbirth imminent is very different than a bleeding with second trimester response. That was very then quickly changed again to a miscarriage. And upon 365's arrival, it was then upgraded to baby out, cardiac arrest in a toilet. So obviously, the call changed 4 different times while en route. Obviously, they tried canceling units, they tried getting new units, they put a supervisor on it, they canceled the supervisor, and Lindsay, with good judgment, said, you better keep everybody coming. Well, everybody was the people from 365 and myself and a driver from engine 361. Did not have EMT, he literally was just a driver. So 365 was first due in. It is EMS 2's district, so we were pretty close by. The engine, again, was only driver only. The back, different, had a different outcome. We were already behind the 8 ball with help. We had some issues with the crew on the scene, significant issues with the crew on the scene. We had to manage between her and I. Upon Lindsay's arrival, found the mom to have some bleeding. Mom was a substance abuser, had polysubstance abuse while she was pregnant with the pregnant, had admitted to substance abuse about 24 hours prior to the delivery. She had had intercourse that evening, the evening before, had had heavy bleeding throughout the evening, called 911 when she got up to go to the bathroom, and baby was born. And no prenatal care. We had asked multiple times, obviously Lindsay was the first person there. She had asked, if I'm not mistaken, when was your due date? Have you received any prenatal care? The house smelled very fragrantly of the substances that they were using, so we were aware that that was one of the substances. No. Mom had not gotten her 20-week anatomy scan, so we didn't even have that to go off of. If you have a mom and you can say, hey, have you had your gender scan? And if they say no, then they're probably below 20 weeks, typically, unless you go to one of those little fancy places where they can peekaboo ICU or precious moments things, whatever they are, for like the gender reveals.
I'm assuming they didn't have a check.
No. I'm gonna be pretty firm with the fact that that was probably not in their option plan. They didn't set a big balloon display out and everything else. So right off the bat was just the dispatch information and your initial presentation of baby being born into a toilet, not knowing the gestational age. What are some of the already complicated issues going on in the scene?
Retrieving the baby.
Okay, treating the baby.
Retrieving the baby, like out of the toilet.
Oh, retrieving. Sorry, they said retrieving the baby, not treating. What'd you say? Limited resources.
Inability of staff.
Very much so, yes. Inability of our staff that we had on scene.
I was curious about the trauma of the baby coming out. Was it an explosive delivery? Was there any trauma sustained? Was the cord still attached? Is it not?
The cord for this baby was still attached. She was still in the toilet. Yeah, a good amount of blood loss was on the scene. So from the initial time of dispatch, there was a 11.5-minute time from time of dispatch to when Medic 365 arrived. And at the time of dispatch, baby had already been born. So already 11 minutes had gone by with no resuscitation efforts. Baby was still in the toilet, very stoic. Like, holy crap, this thing's in the toilet, really. Didn't attempt to retrieve it out. She, I guess, assumed it was a miscarriage.
Her third child.
She had had
And then she had a miscarriage, I think.
prior to this.
Or no.
Was the mother still on the toilet?
Say that again?
Was the mother still on the toilet?
Straddling it, right?
Placenta not delivered?
Placenta was still attached. Placenta was still attached to the baby.
Where was the placenta? In the toilet or in the mother?
In her. Still, it was still attached to her. So that was, we're going to get to that part of this too. So Lindsay, being really the only provider on scene out of the medic crew that was there, she had to retrieve the baby out of the toilet, grab a blanket, check the baby out real quick. Again, goes back to, hey look, slideshow. It goes back to the idea of a rapid evaluation of a baby, right? Term, tone, breathing or crying. We didn't really know anything. The baby wasn't breathing or crying, so now Lindsay does what she does best, uses her outside skills of determining gestational age and trying to figure out if the umbilical cord was pulsating. She actually auscultated while she was there. There was no auscultated heart rate. She couldn't hear anything. So at this point in time, Lindsay had made the decision the baby was non-viable. She had me continue in. I entered the building and was met with just that. We rechecked everything to verify, again, it's a crazy scenario to have. The baby itself, no marker for under 24 weeks, which I don't know if you can tell me better. I know we've had those really rare occurrences now that we've had like 21 and 22 weekers that have been surviving with some significant, not necessarily GBMC or any hospital here, but over in UK and other places. Maybe you've had one in GBMC, I don't know, I can't speak for you. 22. So 22 weeks is one of their youngest survivable gestation. At 11 minutes, again, with no resuscitation efforts, baby obviously not breathing, no spontaneous movements, poor tone, poor posture. The APGAR score was in the tank. There's really no APGAR score to be had because the baby was very low in gestational age. So we made the decision to package mom up. We asked the parents if they had a blanket that they would like us to wrap the baby in, and we began the grieving process for them. Again, not something that we're taught in EMS, right? We had the break it to me gently thing for adults, like, hey, This is what's going on. But nobody really teaches us how to help families grieve a loss of a baby. Again, it's not an easy thing, but Lindsay and I both having some background outside of just EMS, we dug really deep at this point in time to figure out what we could do best to help mom and dad. So we found, yes.
Was that her clamping the cord?
Yes. She did clamp the cord. We did do all of that.
To take care of mom better.
Yes. So we did do all of the appropriate steps. We clamped the cord, removed the baby out. We took the baby out before mom, so that way I could evaluate the baby. Sorry, I did forget all that stuff. So we did do all of the evaluations. Mom was being taken care of. We got her out to the medic unit. Again, the baby was dried off, cleaned up a little bit, handed over to mom and dad. How many people have children in here? Okay, pretty much everybody. How many people with their children had like newborn pictures? Okay. How many have heard of families who have lost neonates, newly delivered babies, taking photos? So Lindsay and I again dug really deep into our back pockets and said, what can we do to make this better for them and start the grieving process for them? One of the things being letting them hold them, her, letting them begin to cry, letting them have a private moment in the back of the medic unit. Obviously she was being monitored, but we weren't all up in their grills trying to do everything. We let them have a moment together, and we asked, I know it's going to sound strange, but would you like to take photos with your baby while you're here? Because I'm not sure you're going to get the opportunity once we get to the hospital. And you would have thought we gave them $1 million. Wrong, right? They were very happy that we did that. We actually took the time again. Mom had an IV, fluids were hanging, we were doing appropriate care. We don't need to have all of that crazy stuff. But with that being said, we took a moment to take a picture for the mom and dad holding their baby, because it's their baby. So with all of that being said, we made a really tough call. Lindsay really made the call, just confirmed it through other assessments, to not resuscitate. The hardest decision was just that. The second hardest decision was, how do we help mom and dad grieve? Nobody really knows how to do that. So afterlife care in adulthood is important. You know, making sure the family's taken care of, breaking it to them gently, making sure that if they need somebody to be called after their family member we pronounced them or they didn't make it at the scene. All of that stuff is important. But when it comes to neonates and newborns and babies, the whole game changes, right? Because they didn't have a chance to live. So it's a really, really tough thing, especially for people who in this department have suffered miscarriages or stillborn deliveries. It's a very, very tough thing, but it's a very real thing. And this may not happen in anybody's career. They may not ever have to make this decision. But our goal of today is that if you are faced with this decision, hopefully we've given you a couple little things to consider outside of your basic level or your advanced level training that we've had, down to how to determine gestational age outside of getting a number of last menstrual period from a mom, how to take care of the baby. I think we're going to go over a little bit more on how to do that if we do decide to actually resuscitate. With that being said, again, that upside down triangle that we look at all the time in our neonate protocol, again, it's BLS, 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 and last but not least, ALS. Have you intubated a 22-weeker? Have you guys intubated a 22-weeker? So on a sim lab, I have never intubated a 20-something weeker. So if we are doing ALS and as a paramedic, are thinking, oh my God, I have to intubate this baby. There are so many things that can go wrong with a premature delivery intubation. Their palates aren't formed. They have so much soft tissue in there that hasn't been developed. Their lungs aren't really the right places. Yes. We do not have the right equipment, which I have pulled. I was going to bring it, but we don't have it. To decide to do BLS airway management. We have a handful of preemie bags at supply. So all of those things have to be taken into consideration. If you're going to resuscitate, I mean, obviously there's other things. If you do improper bag valve mask placement, you can cause horrible retinal damage to the babies and eye damage to the babies. You can pop a lung. It's all sorts of things that you can do to cause harm to the baby. So BLS before ALS for infants, if you have a baby who's full term, who has meconium staining, who requires, aggressive suctioning or airway management, or septic because of mom, or substance abuse. We described our NAS babies, which are narcotic addicted substance, right? Babies that are born. They tend to have a lot more complications, and with the opiate epidemic that we're having, we're seeing these NAS babies being born more frequently. So all of these things are complications, and again, it goes back to BLS management. If we can't manage the baby BLS measures, we have we're way behind the 8 ball. So with that, I think we're going to go.
Sorry, I just wanted to,
You can have this.
So first thing, so I think this is a golden opportunity because I personally have not been on a neonatal call in 2 years or so. Does anybody have any specific questions about the call, how Lindsay managed separation of the baby from the mother, any of the assessments before we kind of move on? And we can open up the questions to both the crew involved and our subject matter experts. Sean?
Yeah, I'd love to acknowledge the decision at that moment, what you were experiencing when you decided this is mine.
So I walked in. Obviously, mom wasn't sure of her gestational age, and we were thinking 20 weeks. Oops, sorry. The baby had translucent skin, fused eyelids. There was no umbilical pulse that I could feel. I used a stethoscope. I could not auscultate a pulse. The skin was too translucent to even use a cardiac monitor because you put the leads on, it would rip the skin right off. And it was triage. It was taking care of mom, who obviously had significant blood loss and was hypotensive, and taking care of her. And that was how I made my decision.
So one of the questions that I hope other people are wondering, and I'm not the only stupid one, is what do you do when you're not like a nurse or a former nurse or a female that's in touch with their inner, emotional state, and you're also like a BLS or ALS provider, and you're like, I'm not sure. Is it better to load and go and take, mom and baby in a hurry? What do you think about that as a supervisor?
Hey, thanks.
When you show up, I'm asking.
No pressure. I think, again, it's situationally dependent. I don't think there's any one right answer for this. I think that if you have a call that we were presented with, if it had been 2 men or a man and a woman crew, or a bunch of 18-year-old kids coming in to do this call, I think it's situationally dependent. I think it's comfort level. I mean, obviously, I said in the past, like, none of my deliveries in the field have been normal, so I've kind of expected if I'm having a childbirth that's not normal. I mean, my own wasn't. So with her, I mean, personally, I couldn't have asked for a better person to have made that decision because, again, it's a very tough decision to make. So if it was you two on a medic crew, I mean, you can always ask for additional resources, or you can ask the district officer, what the heck do you think we should do? And we'll make a decision together. And I don't think that's an improper answer. I think if you treat the baby and the mom together, it's the best outcome. And if you think of advanced, past life care as an option, I think that there's nothing wrong with that either.
Sir.
Can't make your mind up, you pick the radio up, you call EMRC. ask them for some help. Tell them what you're dealing with. Like what you did, taking a picture of the child with the family. I think that's great. You know, it gives some closure to them. Like you said, by the time you get to the hospital, they're probably not going to do that, but you did a great job.
One thing that we did discuss,
I haven't exercised in like a year, so this is going to be awesome. Working on the dad bod.
Dad bod. One thing that we did, Lindsay and I, prior to requesting the case review with Dr. Vitberg, because I'd had a relationship with the NICU staff at Franklin Square, Lindsay and I had requested through the academy staff a first case review with Franklin Square's chief of neonatology, Dr. Minna. And we had a case review regarding that. He's also on one of the protocol review boards for maternity and OB. He actually made that suggestion to us. He said, you know, if ever in a position where you aren't really sure of what the heck to do, please by all means contact a pediatric base station. And that's something I should have absolutely put in this presentation, because again, it takes the liability off of you as a provider and puts it on the physician at the hospital. They're trained to do that kind of stuff. Hopefully they have an understanding of neonatology or the premature delivery process. And if you paint a good picture to them saying, hey, we really don't have the appropriate equipment to resuscitate this baby, we'll do CPR and try a bag valve as best as we can. But at this point, if we described our baby, I mean, everybody that we've spoken to has said completely non-viable. And which reaffirmed it, but again, consult with the EMRC pediatric base station and they can give you better guidance.
So, yeah, a question I have for our subject matter experts is, we're living through the height of the opioid epidemic, and you had mentioned that this mother had issues with polysubstance abuse. If you do come upon a call like this, and whether it be a premature or term delivery, and you're aware of opioid addiction in mom, and baby has a depressed respiratory effort through which you're working through the triangle and drying, warming, and stimulating, and then you get down and their heart rate is less than 60 and you're starting to ventilate them, is there any role for naloxone for the newborn or the neonate?
It's not recommended in infants because they have a seizure, so we don't give them.
Thank you. Questions? Beth?
I wanted to ask Lindsay, I'm just trying to reenact this in my head, just picturing you walking into the bathroom and seeing mom straddling a toilet with a baby in the toilet. Can you run through the steps of what you did? Did you grab the baby first? I mean, the baby's attached to the mother. I'm just thinking, did you, how, yeah, practically, because mom was hypotensive, like, there's so much to do. Can you tell me what you did?
So the EMT that was actually driving me, as soon as she heard cardiac arrest, she grabbed her gloves and ran right in. No bags, no monitor, no peds bag. So I ran around, got the monitor, got the peds bag, got all my bags, and went in. I saw my partner actually picked the baby up out of the toilet and had a shocked look on her face and had the baby like this, and she said, "What do I do?" So that's when I did I took the baby from her, I did my quick assessment, and I started to explain to the mom, we were not, this isn't a viable patient. I explained everything to her, and at that time, my partner, who also had a young child, second guessed me, and in front of the patient, and then she also, until Missy got there, which was 7 minutes. So I did my quick assessment, and that's when I made my decision, and that's when I cut the cord, wrapped the baby up in a blanket, tried to take care of mom. By that time, Missy got there, and I explained everything to her, and she reassured me that she was okay with my decision not to work the baby, and we went from there, and we had one driver from engine 371.
I actually drove home.
Missy drove me to the hospital.
Dr. Sable.
I'm just curious, for the care for the mother at this point, did the placenta deliver?
No.
Okay. And was the mother bleeding, or?
Mom was, after we got her situated, she had very minimal. I think most of it was when she was standing up, and it was because of it being in the toilet, it probably looked a lot more than what it actually was.
Right.
Her vitals were 113, 60s.
Did you, so you said the placenta had not delivered?
Had not.
And did you deliver it during the course of the transport?
No.
No, okay.
We're in a short transport to Harvard.
Okay. So before I get to the next question, and correct me if I'm wrong, what is the average birth weight of a baby in the United States? What do you guys, what's the verdict? Right. So I found competing answers, 7, 7.5. Who's familiar with what resource do we have scattered around the county that may need to be updated to help us guide resuscitation of children, pediatric? Wait, 6 months? Yes. No. Good answer. So it actually starts at 3.5 kilos. So if the average baby born is about 7.5 pounds, that's 3 to 3.2 kilos. So hypothetically, you could use the bottom column of the Bernius card. Do you guys use Broslau tapes? No? Okay. You're always doing weights, scale weights for, okay. All right. That's the fire whistle. All right. Questions. There was a question in the back. Here we go.
So I'm curious, just in terms of your thought process, whether the time that had elapsed was kind of the key driver of your decision not to work the baby, or it was the estimated gestational age?
The assessment, the fused eyelids, the translucent skin, the weight, I mean, the baby fit in my hand, and my hands are very small, so.
So one of the things that I thought about that might seem obvious, but in adults, after we get what's that?
Carrying food scales on our medics.
Sure, yeah, let's get on that. What do we typically try to do after we get ROSC in adults?
12 leads.
What's that?
12 leads.
Oh yeah, 12 lead. What's another principle of what's that? Right. So actually, the term hypothermia has disappeared a little bit. It's actually therapeutic temperature management. We try. No, you're laughing. I mean, that's a therapeutic temperature management or therapeutic hypothermia. We try to keep them on the cool side. Certainly, euthermic. Is there any indication to cool babies after ROSC during a neonatal delivery?
Usually they're in full-term babies if they have a difficult delivery and it's they develop encephalopathy, so we do body cooling for that.
Question from Dr. Barinholtz.
At what age in the hospital, how do you guys decide at what age you're going to resuscitate?
GBMC under the age of 25 weeks, we give the parents the option. So to do comfort care, if they choose to do that, sometimes the baby will think it's 23 weeks and they come out crying, and even if the parents choose not to do anything, we'll talk to them and say this baby's crying and make it an effort, so we will go ahead and do something for that baby. It doesn't mean they'll always make it, but.
22-weeker that you had, did it survive?
Yeah, some of them do. Because you have to remember, even though it's 22 weeks, we do plus or minus 2 weeks. So even though they said it was 22 weeks and we have realistic data, we just never know for sure.
Did the child have deficits later on? Did you follow?
Some of them do, some of them don't. There's no way to predict that anymore. Yeah, I mean, the medical care for neonates has grown tremendously. I've been doing this for 27 years, and thinking about what we used to do a long time ago scares me that we were doing that, and we would never do it now. So it's amazing.
Who just turned 40, who was a 28-weeker 40 years ago.
Oh, that's amazing. Wow, that's amazing. Fantastic.
So I have a question for the officers. If you're in a tactical situation and there's a pregnant woman, no, I'm just kidding. Because that's every lecture you go to these days. Tactical care of the neonatal delivery. All right. Yes.
I have a question for you guys, just because I'm curious. What do you guys use to cool babies in the NICU?
We have a cooling blanket, and then, yeah. Ours is Blanketrol.
So I guess one of the questions that I had, I was actually talking to one of the nurse practitioners that works in their unit today. So like, what if I get to the scene and baby is actually proper gestational age, 35, 36 weeks, and they're in extremis access. So there's really just like kind of one medication in the state protocols for resuscitation, and that is Epi. And so has anybody here been involved in a, other than board certified anesthesiologists, cardiac anesthesiologists, has anybody actually inserted any form of IV access into a newborn in the field? Can you just comment a little bit on your experience with that? Okay, in their foot? Mm-hmm. Okay.
It was a foot line, a 24 gauge. That's all I could find.
Is there any training in this department for UV access? No, none whatsoever. And if I had actually asked your nurse practitioner about IOs, and she said that in the hospital, you guys just don't. I mean, it's an option, but it's
an option, but we've never used it.
Okay. If you were going to use an IO, what color needle would you reach for? What's that? The small one. That's why you're a supervisor. That's right. It's pink. Yeah, PBJ. Pink, blue, yellow Jello. Okay. Does anybody have any other questions for our two subject matter experts from the NICU and L&D, for our two providers that were on scene that day?
You alluded to the fact that there was a technique that you can use a larger mask on a neonate for ventilation, but you have to be careful. Obviously, yes. If you're using oxygen, you're going to be careful of the eyes.
Yes. So there's a couple things that go into oxygenating babies. I think typically providers, of course, because we don't typically deal with babies or kids often, we tend to think of them as adults, just little adults, right? And I think it's a common thing, and just they're smaller people. Babies don't require the same O2 saturations as adults when they first come out of the womb. It's very, very, very different. You know, obviously we encourage to do a postductal right hand pulse ox on the babies, but again, it doesn't require as aggressive reoxygenation. Typically, I don't know about in the hospital setting, but they typically don't require high flow oxygen. Again, because it can throw off their metabolic levels. Yeah, and it can obviously damage their eyes. So if you don't have the preemie bag valve mask, if you have a preemie delivery or a smaller sized full-term infant, obviously it's just adjusting to make sure that the nose piece isn't all the way up in their eyes. So if you put it down further on their nose, you may have to get a little creative on how you're creating the seal with your hand. Typically the baby's faces are not like our adult faces, where we actually have to use the 3 fingers. And I mean, if you can cover the seal, the holes that you're feeling from there, I mean, typically they don't require as aggressive a ventilation as us adults do.
You actually can turn the mask upside down and put the nose part under the chin.
Yeah.
I've actually contacted the manufacturer about that.
You can, yes. That is an option for those bag valve masks that we have. Do you have any other suggestions on how to ventilate?
That's a great question. I mean, we have everything we need, so it's kind of a different story.
I just want to clarify here, because we run a fire and EMS department here. Hypothetically, if there were some senior EMS management in the room, which will remain unnamed, I just want to clarify, we do not carry neonatal BVMs.
Not on our units.
Okay. Just and you'd reference.
They have a few.
Okay.
I'd say a few, maybe 6 at supply.
And they're not in the supervisor vehicles either. Okay. All right.
I may or may not have
Okay.
How concerned do you have to be about hypoglycemia in neonates?
It's concerning, but It's concerning, but as soon as they get to the hospital, that's the first thing we do in the NICU is check their glucose. We give glucose gel to them, but I would be more worried about them breathing and keeping them warm.
Would you want EMS to do glucose if they could before
Yeah,
getting there?
that would be helpful.
And would you use a heel stick?
Yes. That's how we do all of our blood tests.
All right, any other questions? So,
There's a question online. Do these patients always require transport to the hospital before time of death is called?
so does a non-viable neonatal patient or a neonatal resuscitation of any sort require definitive transport before the pronouncement of death? Yeah, I mean, the answer is no. The answer is no. If your patient's non-viable, no matter what age they are, 1 hour or 100 years, if the patient is non-viable, we have the ability as EMS providers to pronounce death in the field. And when in doubt, that's what base station consultation's for.
With that being said, I think, like in this specific case, I think if mom and dad are in the position that we were in, I think it would be more detrimental to leave the baby behind and transport mom only. I think that's almost barbaric. Again, situationally based, I mean, there may be some questionable things as to...
She was 1.5 years running around, and then dad held her. Both parents were actually pretty calm. They were a little upset after I explained to them, but they were very calm. They were trusting of us, and we tried to build that relationship with them instead of just coming in and saying, hey, we're not working your baby. We explained it clearly, fully, made sure they understood, and made sure that they were okay with it, and then started.
Lindsay, how were you emotionally?
I was just doing what was coming into my head. I wasn't really thinking.
Can I address that? Sorry. Again, soapbox. So obviously we announced in there that the other provider had kind of ran out of the scene. So obviously, as a district officer and as any sort of crew leader, even if you're an EMT or whatever, one of your main concerns is your people after a call like this. I mean, it's not an easy call. Again, she had a younger child at home. I don't know her whole background. She didn't feel comfortable telling us, and that's fine. With that being said, if these are cases that we have the proper resources after a call like this. We did an immediate CISM response. Obviously, CISM is not required, but it's encouraged. We referred her to the appropriate sources. We gave her plenty of opportunities and names and numbers to reach out to. And I think the two of us, I can speak for both of us, we both benefited from sitting down and talking afterwards. So those are calls that you absolutely should take the time and sit down and recover from.
Dr. Sagel.
Just going back for this one thing in relation to transport. So for the mother, you have an undelivered placenta, and you just don't know the stage of separation or if it even separated from the uterus, or whether it's still attached in the baby just because it dilated for other reasons. Although the cord was clamped, you just don't know the degree. So there's still a risk of bleeding to the mother if the placenta is either, any stage, if it's not fully attached or if it's not fully unattached, there's bleeding risk. So there is a time factor where the mother has to go to the hospital.
We didn't delay. We didn't sit there for 45 minutes.
Just addressing the question of how long we would stay.
That, obviously, if mom had some blood loss, I mean, we didn't, one of our concerns was the stability of mom and making sure she got her fluid replacements and everything else like that. So we did what we needed to do very quickly, and I know in the back, Lindsay was in the back with them, still allowing them to grieve and have their time by themselves. Obviously managing mom's blood loss and making sure her vital signs were stable, and throughout transport she was above 100 for her blood pressures.
All right.
Another question online. In the arrest of a preterm infant, how important is it to get venous access for resuscitation?
You guys want to comment?
If you have the ability to do it, would be great.
If you have the ability to get venous access, great. I'd advocate to not waste time getting venous access. And like Missy said, I think 100 times, BLS, 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 warm, dry, stimulate, ventilatory support, and then move forward, ventilations if necessary, compressions if necessary, and drive.
In the hospital setting, do you ladies usually go for the umbilicus to cannulate most of the time? You guys probably don't mess around with unless it's
Lines for premature babies. Yeah.
Can you just describe for the group just briefly what it entails putting in a UV line?
Basically, they just cut the cord and they look for the veins in the artery and they put it in the veins. But if they need an arterial line, they'll put it in the arterial line. They're just lines that get hooked up.
So they're like little spaghetti, like central lines, but minuscule, thicker walled artery, thinner walled vein, snake it down the vein. Okay. And secured with umbilical tape?
Yes.
Okay, I just remember that from a video I once saw. Okay.
Bath without the needle in it work if you were...
We do angiocasts too.
Okay. So you just go for the floppy vessel instead of the stiff vessel and...
So, what I'd like to do to end the evening is I wanted to divide the room into two halves. We can appoint a captain for each team. I have about 20 rapid fire questions that we can go through to go over the kind of like the nuts and bolts of neonatal resuscitation as it pertains to our state protocols. I'll have maybe one of you guys keep score, and then I will give the captain the reward to figure out how to share with the rest of the group. So there's kind of like a nice division here, but there's too many people on this side, so you two can't participate. You guys, of course, no doctor participation, no nurse. If you are a nurse manager, you are excused, and if you were involved in this call, you're excused. All right. So, do you want to just cut it right down the middle? Who's the captain of this team?
Captain Joe.
Who is it? What's the name of your team? Come up with a creative name. Who's the
A-team.
What? The A-team? Would one of you guys mind just keeping score? All right. So we have the A-team over here, and then Ginny's in charge. Ginny's the captain of this team right here. Okay. All right. So what's your team name? The B team. Guys, it's so original.
Better A-team.
It's like it's Thursday night. Okay. So we'll just go through. This is bread and butter taken right from our state protocols, maybe a little more than our state protocols. And then we'll do it the way like my third grade daughter does it. You just yell it out. And if I hear the right answer, your team is getting the right point. Okay, you're getting the point. All right, you guys ready? Okay, here we go. And Lindsay will be keeping track. Age range of a neonate.
0 to 28.
Point for the B team. 0 to 28 days. Name one thing at the top of the neonatal resuscitation triangle. Too fast. B team. So the top. Oh. Oh wait. You just got promoted. We'll keep it. Everybody likes a comeback, so leave it the way it is. So the top of the triangle, dry, warm, position, stimulate. Not a question for the competition, but what's meant by position? What's meant by position at the top of that triangle? What is the implication there for positioning? How would you describe it? Neutral head position. My triangle. Oh my God, calm down. Okay, next question is, what is the second item underneath dry, warm, position, stimulate? What's the second thing underneath? Suction, point, B team. Next question. Heart rate being low. Heart rate being low. What else on the baby's exam? Heard it on the side first. Got to speak up. You guys are. Give it to B. Give it to A. Give it A. All right. What is the ratio of compressions to ventilations for a neonate? Right back there, heard it first. B team.
What is it? Can you repeat it? Is that online?
Sure. The ratio of compressions to ventilations for a neonate is 3 to 1. It is not continuous compressions the way we do in adults. See if you were paying attention. Average weight of a newborn. Give them both point. 7.5 pounds, 3.2 kilos. All right. This is gonna, so how many ALS providers here? Oh, you guys are screwed. How many ALS providers here? Okay. Ready? 4 kilo delivery needs epi. Dose or volume? I'll take either one. 0.04 is the milligram dose, and the volume is 0.4 mLs. Okay, so we'll give B team gets a point. So it is 0.01 mgs per kg. So a 4 kilo baby gets 0.04 milligrams of epinephrine. To figure out the volume, just slide the decimal point over 1. Say that again?
Bernie's card.
Yes, Bernie's card. Actually, I firmly believe in references. I don't memorize any of this stuff. What is the mechanism by which, or the tool by which we drop such low volume medications? What is it called? What is it? What type of syringe? Point. Tuberculin syringe. 18, wrong. 18. Tuberculin syringe, it's a 1 ml tiny little syringe. Next question. What is the threshold at which we are instructed by the great state of Maryland to treat hypoglycemia in neonates?
40.
Point. It's actually 30. Yeah, 30 milligrams per deciliter. When I talked to the NICU staff, they told me you guys use 45. 45.
According to the AAC for the first 4 hours of life, it can be 25.
Wow. Who knew? Now we know. Okay. What is, give me the number, the weight-based fluid bolus for a neonate? 10 mLs per kilogram. Yep, point. So 10 cc's per kilo. Okay, good. Coming down the home stretch. Why, when we start doing BVM ventilation for a neonate with a heart rate less than 100 or respiratory depression, point. No oxygen, okay? So we don't use supplemental oxygen, we just actually ventilate them. So not for points, but why do we not hook our BVM that we don't have up to? So I'm gonna give him a point. Yeah. I don't know what he said, but I felt bad for him. He was kind of going like this, just making some sort of hand signals. Right. So remember, oxygen is a drug, okay? And it has toxicities. So in the adult population, when somebody's mechanically ventilated, we try to wean their oxygen from 100% down to less than 50% as quickly as possible, generally within the first 12 to 24 hours, because it can cause oxidative damage to the lungs. Neonates are much more prone to oxidative stress and damage than adults. So within the first minute of assisting with BVM ventilation for neonates, we don't hook up to oxygen, we just use the BVM that we don't have. And we just get a little chest rise and fall going because it can cause retinopathy, it can cause bronchopulmonary dysplasia, and other oxidative damage to this very fragile person that just joined us in this wonderful world we live in. What are, just yell them out, give points, give me about 4 or 5 causes of respiratory depression in a neonate? Poor lung development. What? Prematurity, point for B. All right, secretions, airway compromise, opioid, just start putting lines up. All right, hypoglycemia, what's that? Give both teams a point for
I like which airway
hypothermia, hypovolemia, 10 cc's per kilo. All right. I asked, when I walked around the NICU today, I asked 2 people, what were the, if I were going to talk to EMS providers, what are the 2 key things that you guys should walk away with as far as resuscitating neonates? Who can tell me what they are? 2 things. They're both one word. No. The word drive is not one of the answers. Stimulate, ventilate. Those were the 2. When I talked to the folks around the NICU today, they said stimulate, and then if necessary, ventilate. Where are our NICUs around the Beltway, and where should we probably not take a neonatal patient? Right, so just a disclaimer, I love everybody, I love every hospital and system, might be applying for jobs of chairs of different departments. So where do we not have NICUs? Northwest? Good Sam? Bon Secours? St. Agnes has one. Okay. Where the NICU level system goes up to level 4. For trauma, right. Should have made that a question. Where are our level 4 NICUs in the state?
Hopkins in Maryland.
What separates a level 3 like GBMC from a level 4?
ECMO, cardiac surgery, neurological surgeries, pulmonologists.
All right, so level 4 are your 2 downtown centers, Maryland and Hopkins. All right, last 2 questions. Give me, with regard to neonatal mortality, the case that was just described, give me a couple things that you can do to help console the mom, the dad, family. Pictures. Contact. Just cleaning off the baby, making the baby presentable, giving it to mom or dad, allowing them to be with the baby, giving them the opportunity to take pictures. Mobile crisis if they're available, calling for a supervisor if you're not comfortable doing any of the above. Okay. Give me a quick list of clues that a neonate is not viable. Fused eyes, translucent skin, cyanosis, well maybe not. Okay, no umbilical pulsation, okay, gelatinous skin, okay. And I think I am fresh out. 3 ways to check a pulse in a neonate.
Stethoscope.
Apical, stethoscope. Brachial. Umbilical. Okay. Give like 2.5 points to everybody. Okay. All right. Did you feel like you learned something tonight?
Yes.
Was this useful?
Yes.
Was it important that they shared their case with you?
Yes.
So I want to say a huge thank you to Missy and Lindsay. And I want to say a huge thank you to Kristen and Rachel from GBMC. And I want to thank all of you guys, and the most important thing you have to do tonight is take this information and share it with all of the people that you work with. Even if you just share 1 or 2 things, share it with the folks you work with, and direct people to the live stream, which is recorded and archived so that they can watch this. And with that, thank you very much for coming.
Dave, thanks for organizing. Thanks for pulling this together and making this happen.
Thank you.
For those who to sign in, text us if you don't see the Google link.